really happy to have Dr. Elise Magnuson here to talk with us about mental illness and dual diagnosis. And I can tell you that she got her Master of Social Work at New York University, and then went on to get her Doctorate of Psychology at Colorado School of Professional Psychology. And I can also say that she has had some teaching experience. She is coming to us from Portland, Maine. So a traveling scholar, a visiting person for us, which is great. And also she is clinical director of Granite Bay Care Incorporated in Maine, which provides services to cognitively impaired individuals who have a history of problematic behaviors ranging from sexual offending to violence and self-injury. And she will introduce herself further, but thanks so much.
Thank you. So I do a number of different things and wear a couple of different hats. At Granite Bay Care, everybody we support has a developmental disability, which means that they have mental retardation or pervasive developmental disorder or autism. And about half of them have antisocial personality disorder and have been really involved in the criminal justice system, which has a whole host of other issues attached to it. And the other half are mentally ill. And I became very interested in this subject because the folks who do mental illness well don't know how to do developmental disability stuff well. And the folks who know how to do developmental disability stuff well get very confused by mental illness. And so it just really sort of piqued my curiosity. So I'm very pleased to be able to be here this afternoon. I cover a lot of material in this presentation. So it would help me to know sort of who you are and why you're here, so I can try and hit your interests more, and if there are things that nobody's interested in, I'm just going to skip them. So if we could start with you.
Well, I'm Steve Tupper. I'm part of the field faculty.
Okay.
26 years. But as I mentioned, coming in, I work at Sandridge, which is a hospital.
I'm familiar with Sandridge.
And in the last 3 or 4 years, I ended up working with those who have high psychopathy, who are developmentally disabled.
Who some people don't believe exist.
The developmental disability or the psychopathy?
The combination.
Oh. Well, you should have been in the group.
I believe it exists, but some people don't.
But I like the population. I really warmed to that group of guys, and it's fun to work.
Okay.
I'm Sandy Cohn. I'm the director for field education.
Okay.
We have 13 field units in the full-time program and almost the same number in the part-time. So I'm here partly for selfish reasons, continuing kind of education for me, but I want to see if there's any information too that we have a field unit as well in developmental and other disabilities.
Okay.
So I may be able to assist with, and I don't think Susan's here, so I'll be here on the instructor's behalf.
Okay. Good.
Hi, I'm Pam Stabb, and I'm a social worker here in Dane County, and I work with kids who have developmental disabilities.
Okay.
I'm Kari Morgan, same thing.
Okay. Okay.
Josh Davidson, I'm the same thing.
Okay.
You're listening.
And I'm Judy Switsky. I'm an advisor to the part-time M.S.W program.
Okay.
And I'm here for dual diagnosis.
Okay.
I'm Andy Meyer. I'm a program support teacher in the Madison School District, and I'm also a parent of a child with
Development.
diagnosis.
Okay.
And I'm Dr. Westby. I'm just a student, and I'm in the mental illness community.
Okay. Okay.
And Christina Gooch is also a student.
Okay. That's very helpful. Thank you. So as I said, I'm clinical director at Granite Bay Care. I also have a private practice where I focus on evaluations and do a lot of forensic type evaluations, a lot of sex offending, and people get very confused when there's also a developmental disability involved, and sort of teasing some of that out. I am also a licensed social worker as well as a licensed psychologist, so I'm duly diagnosed, I guess. We are switching away from mental retardation to intellectual disability. The nomenclature is changing. It's frequently something you're born with. It is unlike a mental illness that you sort of get later on. This is frequently from birth. There's evidence of it from an early age. You know, my guys come with volumes of records. You get evals from when they were 2 and 3 and 5. You know, so there's very clearly developmental trajectory. And it doesn't get better. It's not something you cure. When I'm talking with people trying to help them understand the difference between a developmental disability and a mental illness, for people who are not familiar with either, I often talk about mental illness you can give a pill to. That's something that you can expect to get better. You can't give a pill to somebody for their developmental disability and expect that to fix the developmental disability. In the diagnosing of developmental disabilities, you need an IQ below 70. If you're reading reports, if you're looking at stuff, you need to know that when people use the WACE, which is how most of the IQs are found, there's a range. It's not a precise number. If anybody has ever built anything where, like, you're cutting wood or cutting paper and you measure it twice, because you know that if you do it only once, you're off half an inch in one direction or the other, so you got to hit it just right. The same thing happens with psychological testing and with IQ. So there's a range in that. So I have diagnosed people with mental retardation who have an IQ of 72. I have also said people are not mentally retarded when they have an IQ of 68, because you need the other piece of the impairment in adaptive functioning. Their ability to move through life has to also be impaired, as well as the IQ. So if you see evals where somebody has an IQ of 72 and they're still mentally retarded, it's not that the psychologist got it wrong. And if you see somebody who has an IQ of 68 and they're not diagnosed with mental retardation, the psychologist also probably didn't mess that one up either. We are talking about a very small group of people. The bell curve is sort of the normal distribution of what IQ scores are. Most people are average, which is 100. Most college students are about 112. But to be mentally retarded, you have to be in the bottom 2% of intellectual functioning. And that's really very low. And just parenthetically, I think the people who have the hardest times are the people who sort of right here in this borderline range, because they have none of the skills, but they don't hit the disability level, so they get none of the support either. And when I think about the services that they receive, I often wish they could get the same services. I'm going to skip this part, unless anybody here has a burning interest in IQ and what that means.
There's a working memory.
Working memory is your ability to hold information in your head while you're thinking about it. When somebody gives you a number, like a phone number, and you're holding it in your head, that's your working memory. The analogy that everybody uses is back before we were all on computers and smartphones, it was your desk and the stuff you had on top of your desk. Your long-term memory was your file cabinet. So it's the stuff that you're sort of able to hold in your head. Now with developmental disability, this becomes really important, because I often talk about my guys can't forget what they're thinking about before they're done thinking about it. You know, so if you've got your working memory and you've looked up your password and you hold it in your head while you go and put it in your computer, they will forget it between looking it up and going to put it in. If you're doing treatment with them or trying to help them access services, you can't expect them to hold it in their head, because it's going to fall out. And it's not that they're being a pain in the neck. It's not that they're being difficult. It's that they can't hold it there. So that's what the working memory is, which is a little bit different from the processing speed, which is how fast you can think about things. how fast you can make connections, how fast you can put things together. The best way I've heard intelligence sort of talked about is it's the engine under your hood. And if you're going up a mountain in a Ferrari, you get there really fast and it's nice and shiny and sparkly. If you're in a Mercedes, you still get there pretty quickly. If you're in a Nissan Sentra, you get to the top of the mountain. The Ferrari and the Mercedes is there way ahead of you, but you still get there. Many of my individuals are in a Yugo or a moped. They can still get to the top of the mountain. It just takes them a lot longer. And they're a lot slower getting there. Which is, in my context, why we can manage them in an outpatient environment. Because hopefully the staff is smarter than they are and can get there first, although sometimes not. Other questions about intelligence? What it means? Why it's important? Okay. So when you're assessing, I've sort of geared this towards clinical assessment. When you're assessing, but it would also work for services or case management. When you're assessing somebody, it becomes very important to know who the guardian is. Because the guardian is the person who can give consent for treatment or to receive services. So that's always very important. If they are not their own guardian, they cannot consent to treatment, they cannot sign releases of information. So just bear that in mind. A big problem, I think, that gets overlooked in assessment is figuring out whose problem is it. Sometimes people legitimately come in, the developmentally disabled, and they're saying, this is my problem, it's bothering me, I want to fix it, I want to change it. But in my experience, very often other people are coming in saying, this person has a problem. They're not doing it the way we want them to. They need to change. And just like for those of you who do marital counseling, when people come in and say, my spouse is messing everything up, they need to change, it doesn't always work well. So you want to pay attention to whose problem is it and what is the problem. I see a lot of they're not doing what they're told. Remember, they are people, and most of us don't do what we're told. You know, if I got brought in every time, you know, if I was sent to therapy because I wasn't doing what my boss told me to, and I wasn't doing what the people in my house told me to, and I'm here visiting family, and if I wasn't doing what my sister and my mother told me to, and so that sent me to therapy for being oppositional. So you want to really bear that in mind and try and tease that out as much as you can. Another issue that you need to be very mindful of is that individuals with developmental disability often have a very difficult time talking about their internal process. So when you have somebody else coming into therapy and you say, well, how did that make you feel? You know, we're social workers, we care how people feel. And we expect them to be able to tell us. People with developmental disabilities may have a very difficult time telling you. When you say, well, you're doing your cognitive behavioral treatment, and you say, well, what did you think? Because their working memory is so poor, they may not know what they think. So you need to be mindful of that. The other thing that often happens is that they can't connect the right stressor with their reaction. So what you need to do then as a clinician or as a caseworker is really get a thorough history. You can't count on them saying, everything's fine, to mean that everything is actually fine. And when you say, well, is anything new in your life? And they say, no. You can't count that nothing has changed. So you really need to do a thorough assessment of what's been going on, what's changed. And they may not connect what is very obvious to you. which is why you need to do the assessment. Often, individuals with developmental disabilities get referred because they have challenging behaviors, which, this is my personal thing, I hate that as a phrase. I think it's rather demeaning. And what we really ought to say is, something along the lines of, they're annoying everybody around them, or they're causing problems. And what I find very helpful is no matter what the behavior is, you want to think of it as a form of communication. They're trying to tell you something, they're trying to do something, much like all of us are with our behavior. So you want to think about it, what's the message being sent? In that, you need to really understand the context of the behavior. The individuals with developmental disabilities, particularly ones getting services, have a whole lot of context all of the time. They're getting different staff in and out with different personalities, different ways of doing things. They're in different settings. They're at home, they're in treatment, they're in day program. So you really want to be able to tease out what's happening when, with whom. And using a good strengths-based model, when does it not happen? Under what circumstances, with whom? Because you can get a lot of information that way. What you can glean from that is what are the things that are, what are they trying to communicate? If I'm only hitting you, maybe Peggy's a jerk or isn't nice to me. But also it may be that somebody over here is able to work with me in a way that's more effective, that I can tolerate better, and you can replicate that with other people. So finding out those moments when it's not happening becomes really important. You need to find out what happens before the behavior and after it. If you're thinking about good learning, and you're remembering your classical conditioning, and you're remembering your, I'm just totally blanking on the operant conditioning, and punishment and rewards, find out what's happening before as well as what's happening after the behavior. Are they trying to escape something? Are they trying to get something? Are they anticipating something? So really doing a good analysis of the precursors and the postcursors. What are the rewards coming out of this and what are the punishments? I often talk about my guys might be mentally retarded, but they're not stupid. Which means if they're trying to get something, what they're doing is working. Assume the behavior is working on some level. That if I don't, and I'm going to pick on you because you're sitting right there. If I don't want to go with Peggy, and so I hit her, and then I don't have to go because I'm now sent over here, assume it's working on some level. And so our job as social workers is to figure out what or why or how is this working for them. That's that communication piece. You want to find out when it started, how long it's been going on, and as all good social workers sort of ask, why now? Why are you coming in now? What has precipitated the referral? You need to speak with somebody who knows the individual well, preferably somebody who has seen the behavior, who knows what's going on. Again, because the individual isn't going to be a good self-report person, you want another point of view and to sort of understand that from other people. I know one of my biggest frustrations is when somebody gets sent to me and somebody who has never seen the behavior comes along with them, who's only got it through third hand, comes and says, well, they're not nice and they're being oppositional. So I start to ask my questions. What are they doing? Well, I don't know. I've never seen it. So when you're doing your interviews, get somebody who knows the individual well, somebody who's seen it, who can put some words to the experience. That becomes very important. One of the tricks I've had to learn is get the third-party informant to just describe the behavior. Don't ask them what's happening, because then they'll give you these global things that are really not very helpful. But ask them to describe it play by play by play. You know, I'll say, if you were writing a screenplay, what does it look like? And then they can sort of tell, well, they walk over here and then they hit, and then they cry, or they sit in the corner when you say it's time to go to lunch, and they, you know, then you get much more information. And lay people often will use clinical words, will use social work concepts inappropriately, I found. And so it's always helpful to make sure that you've got the right meaning. You want to gather information about changes in eating, sleeping, and interest in activities. Those are sort of big markers for depression and anxiety and other mental illnesses. And when you're assessing somebody's internal state, are you depressed? Are you anxious? Are you manic? And they can't tell you, and I don't care how good the person is, nobody else can tell you your internal state. Finding these external markers can be very, very helpful. And so when people say, well, they've started sleeping a lot more, or they're a lot tireder, pay attention to that. Pay attention to people who are suddenly not hungry, or who used to really love going to day program, and now they're not so interested in it. You know, those are markers that you can pay attention to. Find out about changes in living situations. I don't know how it is out here, but I know where I am, people often end up moving a lot, and even within the same agency. So while they may not have changed agencies, they may have changed programs or houses, and that can be a big source of stress. And again, if the problem's been going on for a while, find out why they're coming in now. You absolutely, much more so than with non-developmental disabilities, need to assess for medical problems. Absolutely, absolutely, absolutely. I think the biopsychosocial stance and orientation is important across the board, but I think with individuals with developmental disabilities, it is super highly critical, and a couple of other, you know, adjectives in front of that. You need to know that things like Down syndrome is associated with thyroid problems, which often mimic depression. So you need to make sure that's assessed. Constipation can cause internal pain. I'm going to assume that everybody in here has been constipated. But you sort of know what's going on and you fix it. You eat your prunes, you know. But with individuals with developmental disability, they can't, all they know is inside hurts. And we have a number of individuals who, when they get constipated, their challenging behavior skyrockets. So you want to know that. Also, just by the way, constipation can kill you if it gets bad enough, which I didn't know, but I find appalling. We have one woman who I work with who's 22, and she's right on that cusp. And she is a cute woman, girl, who looks at first blush like any other 22-year-old woman. You met her in a bar, you wouldn't know that she was developmentally disabled. And she would cut on herself, she would get in more restraint, she'd be more aggressive, you know, on a relatively regular basis. It wasn't until we figured out, and actually it was a line staff who figured it out, this happened every 28 days when she was premenstrual. once we were able to help with that, things calmed way down. But what she wasn't able to do is say, hey, I'm feeling really irritable and PMS-y. I'm going to go take some Motrin. And this is where getting that third-party report becomes really important. Ulcers and heartburn, again, their experience is just my insides hurt. There's burning, or I can't eat, I'm uncomfortable, and I don't know how to say, wow, I think my upper GI is, a little inflamed, and I'm going to have to lay off the spicy. They can't do that. And again, they may have a hard time identifying the sources of pain, where the pain is coming from, why they have pain. And so that can also contribute to behaviors. One of my favorite clients has a major depressive disorder with psychotic features, as well as mental retardation. She has a huge history of trauma and bad family. And her stomach is in constant pain. It always hurts her. And we work really hard to try and figure it out. We've been to doctors and haven't been able to sort of tease out what this is. She's had colonoscopies, you name it, we've gotten it done. What it took us a while to figure out is that when you drink 4 liters of Mountain Dew in a 2-hour period, you're gonna get a stomach ache. She still can't connect those 2 events, although the rest of us finally have. And when she is in pain, she becomes very aggressive, assaults staff, assaults her, tries to kill herself. She makes suicidal statements, and gestures of varying dangerousness, some of which are funny, some of which aren't. But all she knows is I'm in pain and I need the pain to stop. So you really do need to assess for medical issues. Assess for substance abuse, drugs or alcohol. I scoffed at this because I work at a residential program, and so I know my individuals aren't drinking and using drugs. I know this. Until they started coming back from day program drunk. And they would go home and visit their parents and come back still stoned. So you do need to assess. You also want to assess for medication side effects. And there is a huge tension when you live in an institution between needing to be well enough behaved so you can live with everybody else and not being over-medicated. And when I see a lot of individuals who I believe are over-medicated. And so the medication they're on to reduce their agitation may also make them lethargic and make them lose all interest in fun activities and make them not want to do anything. And then people are like, oh, they're depressed. Well, no, they're not depressed. They're over-medicated. And so finding that line. Medications can make you anxious as well. And then my favorite is when people give medications to counteract the side effects of the medication that they're countering the side effects for. And that just never seems to go well. And also pay attention to nicotine and caffeine. Those can have huge impacts on people. And for people who can't regulate that intake well, my client who drinks 2 liters of Mountain Dew, that can also have an effect, as can the withdrawal. When somebody decides, okay, you are drinking too much caffeine, you must stop now, because it's not good for you. I have to say, the worst 6 weeks of my entire life were when I decided to go caffeine-free. It was awful. Heroin has nothing on going caffeine-free. So pay attention to that as well. when thinking about mood disorders, your depression, your mania, dysthymic disorders, hypomanic disorders, remember that you're trying to assess an internal state for people who are not good at explaining their internal states. So again, you want to look at the behavior and think of that as communication. You know about the internalizing, externalizing. There's sort of two ways to deal with your distress. One is to turn it inward. One is to turn it outward. They may do a lot of turning it outward. They often don't have a lot of repertoires of behaviors. There's not a whole lot of coping skills that they've learned and can use and can draw on to manage it. And as we said, talking about their energy level, the sleep-wake patterns is a good marker, as well as facial expressions. When you look at the diagnosis for depression, and they talk about feelings of hopelessness, and when you're trying to assess somebody for hopelessness who is living in a place they don't like, with random people coming in and bossing them around, knowing that they're never going to live on their own, they're never going to have a family, and the same sorts of things that everybody else wants, and you're assessing for depression, how much of it is just their life and reality-based, and how much of it is a mood disorder? It becomes really important to sort of suss out. When you're thinking about anxiety disorders and what to do around that, again, it's hard to assess an internal state. It's hard to assess whether somebody's struggling with their working memory, and that's why they sort of have to keep going back over something, or because they're anxious. So you want to look at, again, some of the external behavioral things. Are they sweating? Are they shaking? Are they flushing? Are they more irritable than usual? As those markers when you're looking at your diagnoses, rather than do they feel on edge? Because that's hard to gauge. I think psychotic disorders are unbelievably hard to diagnose effectively, A, in general, and B, with this population. And you have to have somebody who's verbal. So they have to be on the mild end of mental retardation. By the time you start hitting the moderate end, while they may be able to speak, their ability to communicate verbally gets pretty significantly impaired. And if you've got somebody who's nonverbal, I would argue you pretty well can't diagnose a psychotic disorder. I don't know how you assess somebody for a thought disorder when you can't hear their thoughts. How you diagnose a delusion when somebody's not talking to you. So you have to have somebody who's verbal. So somebody comes in and they say, I think they're schizophrenic or they've got a psychotic disorder, and they come in your office and you say, well, do you see or hear things other people don't see or hear? And they're going to say yes, and then start telling you about all the things that happen when they're alone, because nobody else is seeing or hearing them. So you have to get really sort of careful. And again, the internal experience of a psychotic process is often hard to explain when you're very bright and very verbal. And when you're not, and you're trying to say, wow, I hear these voices, and they sound like people, but there aren't people there, is hard. So I often talk about, do you hear people talking when they're not there? That sort of very specific, concrete stuff can be much more helpful than saying, do you hear voices? And if anybody finds a way to really concretely explain the difference between the voice in your head and the voice outside your head, let me know, because I haven't come across it yet. So you want to be careful. Are they thinking and hearing their thoughts, or are they hearing voices? One of the particularly important things is to watch and see if they're responding to like there's something there that when there's not. I was sitting with one client trying to figure out if he was, psychotic or not. Was he actively psychotic? Were the meds working? Were they not working? He had post-traumatic stress disorder, so were these flashbacks or were they actual hallucinations? He also had a brain injury. He would have been perfect for Sand Ridge. And how much of it was that? And then I noticed he kept looking over in the corner. And he would talk and he'd look over in the corner and we'd talk and he'd look over in the corner and we'd talk. And so I finally said, "What are you looking at in the corner?" And he says, "The lion." I'm like, "It's a psychotic disorder." I got this one. There are no lions in your flashbacks. The brain injury doesn't make you see lions. We've got a psychotic process going on here. When you're assessing for delusions and you're working with people who work with individuals with developmental disability, they often, and I don't know why, but they often dismiss it as just sort of a crazy idea and then try and talk people out of it, which just doesn't work with delusions because that's the nature of a delusion. You can't talk people out of it. And so I find that staff are pretty reluctant to talk about it because, that's crazy. That's not true. Or they simply dismiss it. I have one individual who, if you ask him, will very carefully explain to you that he works for the FBI and what he does for them in great detail. You'll be pleased to know at the moment he likes me, so the FBI is on my side. It's always not good when he doesn't like me, because then the FBI is going to come and get me. But again, it becomes tricky in sort of figuring out what's true and what's not true. And when you're paranoid and everybody is out to get you, is that a delusion? I mean, by the time it's the FBI, you're kind of okay. But when all the staff hate you and they're out to get you, and they're trying to make you miserable and they're trying to sabotage you, maybe it's true. Maybe you're kind of a jerk and nobody really likes you and they're all actually out to get you.
Or they're jerks.
Yeah, or they're jerks, and they don't understand what you need and so they're not managing you well. I have one individual who I work with who's currently sitting in jail, so I'm not working with her at the moment, who was absolutely certain that staff were trying to screw her up and staff were trying to make her screw up and get in trouble. And she is a classic psychopath. And I dismissed a lot of it because she was being difficult and she was doing a whole host of other things, running away, committing a number of crimes. And so I really just, she's just being a pain in my neck. But then after she's sitting in jail and I start sort of looking back over it, I'm like, I wonder if staff are actually out to get her. It seems entirely possible because she's making their life miserable. So you want to be careful about that. You want to pay attention to thought processes. And are people's speech becoming disorganized and their thoughts getting tangential because they have a poor working memory and can't remember what they were talking about, or because their thought process is that loose. So I do think this is one of the trickier areas to diagnose. I have had a number of large fights about whether or not people with developmental disabilities can have a personality disorder. I believe they can because they have personalities. You remember your personality disorder is a pattern of thoughts, feelings, and behaviors across situations that's problematic. They have thoughts, feelings, and behaviors, and if it's across situations, you can have a personality disorder. As I've mentioned, there are a number of people who do not believe you can be both mentally ill or mentally retarded and a psychopath. I believe you can. Because I believe, and at this point I'm talking about in the mild range, not in the moderate or severe, because that gets much harder to assess. And so theoretically I believe it's possible. I just think we don't know enough to be able to assess it yet. You do need to rule out the impact of the context. And living in institutions, living in group homes can really influence how people respond, how people react. And so you need to really tease that out. And again, remember when you're diagnosing your personality disorders across all areas, long-standing patterns. But I absolutely believe you can be borderline and mentally retarded, or antisocial, or narcissistic, or dependent. Dependent is much tougher to tease out, but I do believe you can actually have a dependent personality disorder and be mentally retarded. Where that gets tougher to tease apart is they really are dependent, and they really can't do a lot on their own. And navigating situations that you don't understand can be very anxiety-producing, so you want to rely on somebody else. That's not the personality disorder piece. So again, you want to use behavioral observation as much as you can. You want to get as many reports from people, sort of looking across the broad spectrum, rather than the one staff who comes in and says, everybody thinks she's borderline. And you say, well, why does you say that? Well, because she's really emotional. That's not enough to make the diagnosis. In ruling out the impact of living in institutions, I have had individuals come to our agency, and we have a different model than a lot of the other ones where we live, or where I live. And they'll come, and you're expecting hell on wheels. This person is ready to go. We just took an individual in who, when upset, puts things in her eyes and in her ears. She puts Parcheesi chips, she puts screws, you cannot sanitize a room well enough to keep things out of this woman's eyes and ears. And when she came to us, she was having 6-person restraints, on a daily basis, trying to keep her from poking things in her eyes. And she would get mad at 6 people sort of glomming onto her, holding her down, so she'd get assaultive. And she's mentally retarded, but she's not stupid. So when she figured out she had MRSA, which is a communicable disease, she started biting herself and spitting in staff's face, trying to give them MRSA. So we're like bracing for this woman to come. Okay, we're ready. Different situation, very different behavior. She still puts things in her eyes and in her ears, but it's about once or twice a week. When we restrain her we have a different restraint model, so we only do 2 minutes, and then if you need to re-engage, you re-engage. But instead of hours on end with people like holding her down, 10 minutes. So people respond very significantly to the environment they're in. And when you're diagnosing personality disorders, you really need to pay attention to that. You cannot rule out the effects of abuse. Individuals with developmental disabilities end up being abused much more than the general population. About 40% of people end up having been physically or mentally abused. And again, it gets tricky to tease out. They may not recognize it as abuse. So when you're doing your history and you say, were you ever sexually abused? And they'll say no. And then you'll find out that they weren't sexually abused, but they were having sex with their uncle, from the ages of 4 to 12. Wasn't sexually abused. He never hit me. So you need to ask very specific questions. You need to help them recognize it, which is always dicey because if they aren't traumatized by it, you know, do you want to increase the trauma then? I mean, that's a whole different conversation. They may be afraid to tell people because, again, you have somebody who's very dependent on their staff, very dependent on their family, you know, and it's the same with kids, and they may not want to rock the boat. And if it's not that bad and they're getting some goodies in a relatively bleak life, it may not, again, from their perspective, make sense to tell people. And unfortunately, the system is filled with abuse, and they may have been abused before and told and nothing happened, so why would you tell again? So that's often a factor, being afraid to tell. On the flip side, they may make false allegations to get some sense of control, some sense of control over the environment, some sense of power. You know, if I have staff coming into my home, into my residence, and I don't like them, and I don't actually hire them, although we, at least in Maine, we talk about, well, you've hired them. It's not actually true. They can't really fire them. They can't say, no, I don't want to work with you today. Send the nice staff. A number of our individuals will say they were abused as a way to try and manage staff. Sometimes it's really easy to tell whether or not they're lying. I've had clients say, they stabbed me. Well, where'd they stab you? In my hand. Can I see your hand? There's nothing. The same woman who is, one of the things about my agency is we work with a lot of our staff are a lot of very large men because they do need to do a lot of restraints. And so I know more men over 7 foot on my staff than I think anywhere short of a basketball team. So the woman who's sitting in jail was, you know, being a pain in the neck to staff, and she had been restrained, and she called the police and said, my staff strangled me. And the police looked at her, she's about this tall, a white woman, and they looked at the staff, who was Claude, and I'm not exaggerating, who has hands twice the size of mine, and they looked at her neck, and they looked at Claude, and they finally said, there is no way that man strangled you, and there are no marks. So sometimes it's a power play, a way of getting in control. And getting back to them being retarded but not stupid. About a week later, staff caught her holding her hands, trying to bruise her neck, so that next time there would be marks when she said, staff strangled me. One of the things that I'm going to assume you guys have it out here is when people say, I don't feel safe. I don't feel safe, I need fill in the blank, whatever that is. And I never know what that means. And I never know how to address it. Safe from what? Safe from whom? And very often it gets very vague. And people who are trying to manage their environment very quickly learn, I don't feel safe, can move people and move things. So again, you want to pay attention to that. Questions on assessment before I move on to treatment stuff? No? Okay. Again, I recommend talking to the third party who brings them. That's very important. When somebody is in residential treatment, they have a whole lot of people in their lives, and they all have opinions. And they will all share them with you and the individual and tell you what needs to happen. And one of my biggest pet peeves is when a very good meaning staff or sort of person will say, well, I think you have an attachment disorder and you really need treatment for that. And they don't. You know, somebody's read something on the internet and, say, oh, look, they have all the same symptoms. So just bear in mind that while you're treating an individual, you also need to educate a team. And a lot of people around that. One thing that's often helpful when they're coming into your office and you want to know what's gone on in the last week is having a book of some sort that gets passed back and forth so that you can find out sort of what happened in the last week. Individuals will say, it was fine. You find out they were restrained 3 times and ran away once. So that's a good way of getting the information. I have had debates about whether or not people with developmental disabilities can benefit from treatment. And it's typically with people who don't treat them and don't understand them. I believe they absolutely can benefit. And I learned this as a clinician. I was fresh out of graduate school. I was doing community mental health work, and I had a woman come in she wasn't retarded, but her adaptive functioning sort of just flipped her up over the edge. And I was like, she's just not smart enough to do cognitive behavioral treatment. She can't get this. She can't think abstractly. So she's coming in because her boyfriend's beating her and she doesn't like that. I'm like, oh, this is not going to work. About 3 sessions in, I have no idea of what I said. But she looked at me and she goes, you mean I'm giving up my freedom being with him? I said, yeah, he's hitting on you. She goes, I worked hard for my freedom. I don't want to give it up. I said, okay. She comes in the next week because it's community mental health. You come in every week. She kicked him out. And he wasn't coming back. I was like, got it. You don't have to be smart to benefit from treatment. You do have to make some modifications because your working memory inhibits, because your processing speed is slower, and a number of other things. So be concrete. Do not use a lot of metaphors. Do not tell a lot of stories. I like using metaphors. I like saying, well, it's like this, and then you hope that the individual puts the two together, and then they internalize the experience of having, learned this or figured it out. Don't do that, because they can't move as well from the abstract to the specific. So stay pretty concrete, stay specific. Use simple sentence structure. Do not use compound sentences. Do not speak in full paragraphs. Short, simple sentences. It's easier for them to process, it's easier for them to understand, and you can communicate just as effectively. Don't assign reading. They may be able to read, but it's not going to be a strength. They're not going to do it. I know a number of therapists who like to have people go home and read things and sort of think about them. Don't do that with these guys. When you want them to do something, having told you not to go have them read, send them home with instructions. These are not the folks where you can say, well, your homework for this week is to go running 3 times a week. You have to send them home with a piece of paper that says running Monday, Wednesday, Friday. That specific, that concrete. And avoid yes or no questions. I know you get told this the first day of clinical interviewing, avoid yes or no questions. But when people aren't giving you a lot of information, if you're at all like me, you fall into them because you're trying to get, where am I here? Am I starting? Am I stopping? How am I going? Avoid them. Because a lot of people, much more so than individuals who don't have developmental disabilities, will slip into yes or no responses. And they'll just say yes to everything. Yes, I'm feeling sad. Yes, I'm feeling anxious. Yes, I'm hearing voices. Yes, I had a hard week. Yes, I miss my mother. All of those. So you want to avoid the yes or no questions and really keep it open-ended, which then gets a little harder. So I often resort to multiple choice questions. Are you doing this, this, or this? And then you can sort of get out of the yes or no piece, but still have some options for them. They often have learned, they've often been trained to be good. Don't get in trouble, and by being good, that means doing what you're told and telling people what they want to hear. So they may work hard to tell you what you want to hear, regardless of whether or not it's true. I think something that often gets overlooked is that people will often present as doing much better than they actually are. They get really good at faking it, at faking understanding, at faking appreciation for what's happening, particularly if they have a good verbal IQ. So they sound like they know what they're doing. And you'll say, do you understand? And they'll say, yes, they do. And you're like, I'm all set. And they have no clue of what was happening. I was getting consent to do an evaluation. And I said, well, everything you tell me is going to end up in the report. And if there's abuse or neglect, I have to report that. And so you have very limited confidentiality. Do you understand? And he said, yes. And I said, well, what did I say? I have no confidentiality. We're all set. I'm good to go. And for whatever reason, I said, what does confidentiality mean? He said, I don't know. So now I talk about secrets. Nothing you tell me is going to be a secret. I'm going to tell everybody what you've told me. But he said, yeah, he understood what confidentiality meant. I went, okay. Couple of thoughts on treatment, particularly with individuals who are living in residential programs. Think about how much control they have over their lives, or don't have. I had breakfast at 10:30 this morning, and I had peanut butter toast and a toast with marmalade, because that's what I felt like. If I live in a group home, I can't do that. I have to eat breakfast at 8 o'clock, because that's when breakfast is. And if I don't want the eggs and toast that are on the menu, I can't go make my peanut butter toast, because the systems aren't that flexible. So you need to bear in mind they have very little control over what they're doing, how they're doing it, when they're doing it. And as I sort of have been working with, one of the things that I've really come to appreciate with my individuals is how little there is that gives their life meaning. You all have something that got you up. You came here for some reason because there's something important to you. And there's meaning to your life. Whether it's something as simple as you have a job and a family you want to take care of, or whether this is your passion and you can pursue it. But a lot of individuals with developmental disabilities don't have a point to getting up in the morning. They don't have a reason to go through the hard stuff of life. All of you are either in school or you've been through school, so you know school is hard. There are times you want to quit, but there's a point to it. If they don't have a point to get through the hard stuff, there's no reason to. And so helping them find a good life, helping them find something that's meaningful in their lives, that's worth working towards, can become really, really critical, important piece of any treatment. Often what tips me off to that this is the problem is they'll say, he's not motivated. Nothing's motivating him. Well, it's because there's nothing in his life. Where are we here? Don't be surprised when they have a hard time generalizing, when they learn to express themselves at day program, and you're like, yes, we've got this, and you go to the residential program and they can't do it. They just need to learn it there. They often don't generalize from one situation to another very well. I recommend you be skill-based, because it's much easier to teach skills. So when you're being skill-based, think about problem-solving skills, things that we do naturally to solve problems, they need to learn how to do. Think about social skills, relaxation skills, and think about thinking skills. teaching people how to think can become really important. And then just some concluding thoughts. People with developmental disabilities are overdiagnosed and underdiagnosed. I have seen people come in with 15 different, I'm exaggerating, 4 different mood disorders. They're diagnosed with depression, bipolar, borderline personality disorder, mental retardation, and an attachment disorder. I'm like, figure out what the problem is and diagnose that. Or people come in with significant problems, an antisocial personality disorder, and that shows up nowhere. So the diagnostic piece becomes important. Good clinical skills. You know, you're going to have to think. You're not going to, until you get used to it, you're not going to be able to go on autopilot the way that sometimes it happens, but nobody coming out of this program would ever do that. But use your good clinical skills and think about what's happening in this session, and you can adjust to where you need to go. As I've been saying, the biopsychosocial approach is critical. You know, I don't think you can do this work without it. And the impact of the environment is critical. So those are my concluding thoughts. If there are any questions, or I'm told you all have classes and stuff to get to.
Questions from anybody? No questions. Thank you so much.
Thank you very much.